So this talk is about Fuchs heterochromic iridocyclitis, a pretty photogenic disease, kind of a short talk. It's a rare inflammatory glaucoma that causes a unilateral open-angle form of glaucoma. Recent evidence has shown that it's caused by rubella, and that comes from two lines of evidence. One is some PCR evidence of rubella, but also the fact that in countries where there's rubella immunization, the disease is going away, and the patients seen in big uveitis clinics tend to be people who are immigrants who are not immunized as children. Typically middle-aged individuals, there's no gender predilection. Glaucoma develops in 15%. They're relatively asymptomatic patients. They can get cataract, and that can cause them to have symptoms, but in general, they're fairly asymptomatic. What we see is heterochromia, although it's not seen in everybody. You can see in this gentleman that his right eye is lighter than his left eye, and the right eye is the affected eye. So heterochromia occurs in only 80%. That means that 20% don't have that as a feature. Like in the person I just showed, it's usually the lighter eye that's affected, but in this blue-eyed patient, it's actually her left eye and darker eye that's affected. So you can have reverse heterochromia in people who are light-eyed. We see chorotic precipitates that are usually clear and fine and distributed over the entire corneal endothelium. And they can be stellate. So this is a very high magnification picture of a stellate KP. You can see the chorotic precipitate here with these little wings coming off, giving it this stellate appearance. And these two pictures, one a red reflex, one a slit lamp, showing that these are diffuse. They don't settle down below like mutton fat KP can, but they're generally diffusely distributed over the corneal endothelium. Truth in advertising, this patient actually had a different form of uveitis, but just had features that were very characteristic of Fuchs, including these stellate-like KP that are distributed across the corneal endothelium. This is exactly what you would see in a patient with Fuchs. You can see these little KP here with the lines or stellate nature coming out from them. The iris is featureless. I always say it looks like someone took the iris out and ironed it on an ironing board and put it back, because it's missing the crypts and the furrows that you normally would see in an iris. And especially here you can see when compared with the normal iris that it has lost its features. And this is really the single most commonly seen feature in Fuchs. If you could only look at one thing, this would be the one thing you would want to look for. They get these fine neovascular vessels on their iris and in their angle. And these can bleed. They're very fragile. You can even make them bleed by doing gonioscopy. This is a great video that was sent to me by Rob Honkin in New York. And it basically just shows someone having cataract extraction. And every time the pressure goes down, these fragile Fuchs vessels just start to bleed. You can see them bleeding here. As we raise the pressure, bleeding stops. But as soon as the pressure goes down again, they'll start to bleed. Typically, cataract surgery in these patients goes off without much of a hitch, although they do occasionally get hemorrhage. Angle neovascularization also is seen here, but they don't tend to form peripheral anterior synechia like angle neovascularization in things like diabetic neovascular glaucoma. This is that same patient that I showed a video on earlier who actually does not have Fuchs but has the perfect Fuchs finding. You can see this fine neovascularization throughout the angle, 360 degrees, that does not form peripheral anterior synechia. This patient was sent in as a Fuchs patient, but on dilated fundus exam turned out to have sarcoid uveitis. But was such a great example of what to look for in people with Fuchs that I'm putting it in here with the caveat that that's actually not the disease this person has. You can see these vessels cross the trabecular meshwork, cross the scleral spur, and branch on the other side of the scleral spur, and clearly not normal blood vessels, other than that little that loop here, which is a normal blood vessel. They can form posterior subcapsular cataracts. This is a patient who has heterochromia and a cataract in that lighter colored eye. Usually these people are treated with aqueous suppressants. We don't treat them with steroids. They don't help, and they can cause a steroid-induced glaucoma. Their course is much like primary open-angle glaucoma. Cataract surgery is generally not overly complicated. It's useful here to think about the differential diagnosis of heterochromia and glaucoma. When the lighter eye is affected, we think about things that are inflammatory, like Fuchs heterochromic iridocyclitis that we just talked about, also glaucomatous-cyclitic crisis or Posner-Schlossman syndrome, and any chronic iridocyclitis can cause heterochromia with the lighter eye being affected. The darker eye can be affected, again in Fuchs, if you have a light-eyed patient. Prostaglandin usage often causes a darker eye, or sometimes causes a darker eye in the eye in which it's used. Neovascularization, iris nevus. Tumors can cause a darker eye in the higher pressure eye. Iris melanoma. If you have a large posterior segment tumor that's shedding pigment, you can have melanomolytic glaucoma. Siderosis or hemosiderosis. Pigment dispersion syndrome, with the darker eye being the one with more pigment dispersion. Cogan-Reese syndrome, neurofibromatosis. I'm sure the list goes on. The key points here, it's a rare unilateral glaucoma. You don't need to have heterochromia to have the diagnosis of Fuchs heterochromic iridocyclitis. The most common feature is a flat featureless iris. Rubella has been implicated as the cause, and don't treat with steroids.